Thank you guys for this session. So have a break. Let's start surgery. If you can raise your hand, if you can hear. Okay, so let's start with the first station surgery, UTI BPH. Let's read the question. We are after in GP. Patient is 75-year-old, present to the hospital with dysuria. Talk to the patient, discuss the plan of management. See, dysuria, after listening this word, dysuria, after reading this word, there should be a lot of things which should come in our mind. Dysuria 75. First of all, think of red flags things. That's the first thing that we look for in any of the stations. So 75 cancer, that's the first thing, yeah. Dysuria can be, let's see. First of all, yeah, it can be UTI, yes. Dysuria, actually it's UTI station, so yeah, UTI. BPH, patient can have this because of BPH. If patient is having BPH, patient can have repeated UTI infection, patient can present with dysuria. And yeah, prostate cancer. Prostate cancer is one of the important things that we should consider. And the kidney stones and pyelonephritis and epididymoarthritis. So kidney stone, again, one of the causes, pyelonephritis and epididymoarthritis. But patient is a bit young. I mean, patient is a bit old, so maybe epididymoarthritis, I mean, sexual history. You can skip, but it's no harm in asking. I would say go and ask it, yeah? So UTI, BPH, and prostate cancer, definitely need to ask the question related to cancer. Don't miss it. Okay, so associated symptoms. There are lots of associated symptoms that we ask for UTI. UTI patient presents with fever, tummy pain, smelly, cloudy urine, hematuria, or maybe nausea, vomiting. So ask about all these things. And this patient talks a lot, actually. This patient talks a lot and tries to confuse you because he will give you lots of finding in one go and you may get confused. So don't do like that. And ask all the things. Fever, tummy pain, smelly, cloudy urine, hematuria, nausea, vomiting. Yeah. And then we will be asking questions related to the prostatic symptoms. So prostatic symptoms will be these frequency, nocturia, urgency, hesitancy, incontinence, poor stream, poor empty, and dribbling. Yeah, these questions are prostatic related. Patient will give you some of these findings, some of these symptoms. Some of the symptoms you have to ask. Yeah, there are some there are some symptoms which are common for UTI and BPH, but there are some questions which are only for BPH only. For example, in this, all these symptoms, all these 8 symptoms, frequency, nocturia, urgency, hesitancy, incontinence, poor stream, emptying, and dribbling. Frequency and urgency, you can ask for UTI as well. I mean, the patient who presents with frequency and urgency, it can be because of UTI. Yeah. So let's see what question we should ask for all these things. Frequency, you can simply ask how often do you go to loo? That is frequency. What is nocturia? I mean, if patient have to wake up in the night, so that is nocturia. Urgency and hesitancy. Actually, some of the candidates they struggle a bit. What is urgency and what is hesitancy? Urgency is it's a bit urgent to go to loo. If it is urgent to go to loo, that is urgency. Yeah, it means you have to rush to the loo. That is urgency. Hesitancy is you have reached to the loo, but you hesitate. It takes a bit of time before you start urinating. That is hesitancy. So that's the difference between urgency, hesitancy. Then it comes up incontinence. Some of the candidates, they struggle between incontinence and dribbling. So there's a slight difference. Incontinence is you are unable to control the urine. If you are able to hold the urine, it means you are unable to hold the urine. That is incontinence. You are unable to hold your urine. That is incontinence. Okay. And there is one more thing, dribbling. Dribbling is once you have finished your urination, still some drops of urine stains at your underpants. That is dribbling. So there is a slight difference between incontinence and dribbling. Poor stream, how's the stream of your urine? Poor emptying, once you have done your urination, you still feel that you still have to go for urination. So that is a thing that you can ask. So the question is hesitancy, urgency, some of the candidates struggle, and incontinence, dribbling, a bit similar, but don't get confused. All right. So that's the thing we need to ask. So we need to ask UTI symptoms, we need to ask BPH symptoms, and please do not miss cancer symptoms, which is weight loss, loss of appetite, and anemia symptoms like tiredness, dizziness, and palpitations and all. And after that, risk factors are, see, risk factor will be of dysuria will be like, or this BPH UTI is age. As age progresses, patient can have UTI because of BPH maybe. Renal stone, yes, renal stone can lead to UTI, and large prostate, yes. So these are the risk factor and some the causes. Examination. What examination we do? In all the station, we usually do general physical examination, vitals. And in this station, as we are suspecting, it might be prostate as well. So do DRE, digital rectal examination. Usually, examiner will give you some finding. Yeah, you have to mention about examination. You need to mention about the investigations as well, like routine blood, urine dip, all those things. Yes, USG and CT urogram. So initially you'll mention about the examination, GPE, general physical examination, vitals, and digital rectal examination. And you'll mention about the routine blood, and you'll mention about urine dip. Yeah, and after that, what happens in this station is examiner will give you a piece of paper where the findings for examination, the finding for the investigation, they have been written. Okay. All those things. The findings are usually there is nitrates and there is leukocytes in the urine, and on doing digital rectal, there is a prostate enlargement, and both the lobes of prostate are smooth. That is the finding. So you can now disclose it what it is. Yeah. So the treatment will be, first of all, there are two diagnoses actually in this station. One is UTI, one is BPH. And the main diagnosis, why patient presented to the hospital is UTI. So do not miss the UTI part. That is important because patient presented, the presenting complaint was dysuria. And patient have this symptom from last 1 week maybe, but other symptom like frequency, hesitancy, and all those stuff, patient had from last maybe 1 or 2 months. But patient never came to the hospital. Patient came because of UTI. So you have two diagnoses actually. One is UTI and one is BPH. So do the management of UTI first. One is symptomatic, and the antibiotics we usually give is nitrofurantoin and trimethoprim. So make sure whenever you're giving the antibiotics and all, make sure in the past medical history you rule out allergies. And this old man is usually allergic to penicillin. Yeah, we know that the drug of choice is not penicillin, but still you need to ask all those things in the history itself if patient is allergic to the thing. All right, and give some general advices. General advices, what we can give, it is drink plenty of water, and also you can say don't drink plenty of water in the evening time because patient might give you nocturia. Patient is going to the loo in the evening time. Yeah, so that can happen. So make sure you ask about all those things and drink water, plenty of water in the morning, not in the evening time. Yeah, and what else we can say? See, one of the most important complication of UTI is confusion. Patient can go into confusion. If patient is old, this patient is old, patient can end up into confusion. So make sure you mention about that stuff, confusion. So how you can mention about confusion? You can give as a warning sign. So first of all, make sure you take social history in the station. So who is living with the patient? So if patient is living alone, it might not be a good idea to send the patient home. So if someone is there, for example, the wife is there, then it's okay. But give warning sign, and that we will also inform to your wife that if you behave in a bit odd manner or you are confused, she can bring you to the hospital. Yeah. So that is the thing. So give warning sign and do not miss social history. Very, very important. Yeah. So that's general advice. And after that, we need to do the management of BPH. The management of BPH is simply like giving these medications. Two medications we usually give temsilosin. Temsilosin is alpha-1 receptor antagonist, and finasteride is 5-alpha reductase inhibitor. So what's the function of temsilosin? It's not like we need to tell temsilosin. We don't have to tell the name of the drug to the patient. What we need to tell the function of medication. What's the function of temsilosin? Temsilosin actually, it just relaxes the muscle of the neck of the bladder so that you can pass urine easily. That is temsilosin. What is finasteride? Finasteride will help to reduce the size of your prostate. So usually we give these medications. Yeah, and the final plan is a surgery, but you don't need to mention about the surgical option of prostate at this point of time because initially we try to tackle the situation with the medical management. Yeah, so that was a question. This patient talks a lot, so make sure you will handle him well, and he talks a lot, and it will be really helpful, because in this we have two diagnoses. We have diagnosis for UTI and for BPH as well, so a lot of stuff to be covered, and this patient will help you. This patient will tell you a lot of things in one go. So make sure you listen carefully. Don't repeat whatever he has already mentioned, yeah? And don't miss allergy, as you're going to prescribe antibiotics in this case. UTI female, that's again the same kind of station, but lady is young here, 27, came with abdominal discomfort. But abdominal discomfort can have like plenty of differentials. So differentials we will be asking it. So UTI can be pyelonephritis, ectopic pregnancy, appendicitis, PID calculi. All right, so these can be our differential: UTI, pyelonephritis, ectopic pregnancy, appendicitis, PID calculi. Yeah. So just see what kind of positive things that your patient will give. And this patient will give burning sensation in the urine, UTI stuff. Yeah, burning sensation, and she will give the pain and discomfort mainly in the suprapubic area. And you can ask about the pyelonephritis as well, any pain in the loin area. Ectopic pregnancy, ask about the LNP. Appendicitis, ask where is the pain, if it is shifting pain or not. PID, ask about sexual history, very important, and history of any stone. Yeah. Associated symptom is again the same associated symptom as we discussed in the previous station: fever, tummy pains, cloudy, smelly urine, hematuria, nausea, and vomiting. What are the risk factors? The risk factors are if the patient is sexually active, that's a risk factor. I mean, age and kidney stones. Yeah, so these are the risk factors. Examine actually the same station, but make sure, see, that is UTI BPH. This is only UTI. So you can ask some questions which are a bit like common. That is for UTI symptoms like frequency and urgency. That you can ask, but make sure don't ask BPH question from the lady. Yeah. So examination is general physical examination and vitals, and that's it. In this station, then investigation will be routine blood, urine tape, ultrasound, same, and the management is again the same. Yeah, again the same. In this station, if you will read the question says we have to write the prescription. We have to write the prescription. So there will be a prescription paper. As you can see in your booklets, we have put a photocopy of this is how the prescription paper looks like. Yeah, so you have to write this prescription. I mean, you have to write nitrofurantoin or trimethoprim. Yeah, but the thing is, when you're taking the history, this patient is saying, doctor, I'm trying to become pregnant and I'm taking folic acid. Okay, patient is taking folic acid, patient is trying to become pregnant. So what can be the drug of choice? Thing is the trimethoprim, it actually affects the folate mechanism. Yeah, so antifolate. So we are definitely not going to give trimethoprim to our patient. Now comes nitrofurantoin, yes or no? The thing is, nitrofurantoin we don't give a patient is pregnant, but this patient is not pregnant actually. So you can go with nitrofurantoin, or I would say go with this drug, amoxicillin 500 mg. That would be a better option. Go for amoxicillin. That would be a better option. Yeah, and as it is written, general advice will be same like drink plenty of water, and what else? You can tell the patient take shower instead of bath. I mean, don't sit in the bathtub, take shower. You can always tell wear loose underwears and cotton underwears. That is what you can mention, and tell the patient refrain from the abstinence, no sexual activity. Yeah, why? Because the chances of this UTI infection spreading, and also tell the patient not to do any sexual activity till your symptoms subsides and we finish this course of antibiotics. And the course is usually for 3 days actually initially, and short course is enough actually. Yeah, so this is UTI female. Write the prescription first, then explain the treatment. Yeah. UTI confusion. They recently started asking this question actually, UTI confusion. As we discussed, like in the first station, UTI, do not forget to give the warning sign about confusion. Do not miss the social history. So now in this station, this UTI confusion, you have to make sure, like, because, you know, they have introduced this new station. That is, I would say, extension of that station. Yeah. Let's read the question. You are in A&E, patient is 75, brought into the hospital by the wife because of confusion. He was diagnosed with UTI 3 days ago. See, so that's kind of station. Yeah, talk to the patient and address his concern. So this station actually, it it goes like a bit the similar way. What happens is you are talking to them. See the question, talk to them. Them means what? Talk to the patient and talk to the wife actually. And it's written patient is confused. So actually when you enter into the cubicle, what you will see, patient is lying down on the couch. Patient is lying down on the couch and wife is standing. So you will try to talk to the patient. You will try to talk to the patient, and the patient is a bit, confused. Patient is just talking some words. Who are you? Where I am? Where? What I'm doing here? Something. This kind of stuff is talking. It means he's confused. And then wife will divert. Wife will you? Wife will tell you what you're supposed to do. And then wife will intervene and will change. She will tell doctor, I don't know what happened to my husband. He's just talking something like this. That where I am, where, what happened, and he's a bit confused, doctor. Yeah. And then you just have to make her sit and start taking history from the female, from the wife, because husband is confused. That's why they have mentioned talk to them. So what you should do, actually go to the patient first, yeah, and then you can start talking to the wife. And then wife will tell you the same story. Doctor, actually, he was diagnosed with UTI 3 days ago, and he was prescribed trimethoprim. He was taking it as prescribed. He was absolutely fine. I don't know what happened like 3 days ago, and he was behaving like in this way now. He's a bit confused, doctor, this and that, and I was taking medication properly, all those things. So you will take a bit of history for the previous time. So why did you brought him to the hospital last time? Doctor, he was having dysuria, he was having frequency, nocturia, dribbling, all those things positive. That's why we brought him to the hospital. In the hospital, he was examined, and investigation was done, and he was diagnosed with UTI, was given primethoprim. He was absolutely fine for doctor last 2 days, but I don't know what happened yesterday. He started behaving in a very odd way. He's behaving that he's confused. I don't know what happened. That's the thing. Then what you will do is, after taking history, past medical history, personal, everything, you will just examine the patient. After that, the examiner will give you the vitals in this station. Yeah, you will be given the vitals. Vitals will be again deranged. Deranged in the sense the same. It's sepsis vitals actually. The blood pressure is low, pulse is high, the temperature is again high. So that's the thing. So you will admit the patient and you will give the treatment. It's like this time it's IV antibiotics. We will keep the patient in the hospital. That's it. And this lady is asking why this happened. So you will say he was diagnosed with UTI and this is one of the complications. Actually, in old patient, in young patient, what happens is UTI and other things, they get treated without any problem. But in the old patient, it can lead to confusion. This is what happened to your husband. So what we have to do is we have to keep him in the hospital and do further investigation and give him IV antibiotics when we will send the urine for culture and all everything. Sometime recently, actually, they started adding one more line that in the question itself, actually, he was diagnosed with UTI 3 days ago. Now he presented with confusion and the urine culture has been done and E. coli was found. So sometimes they are mentioning that also, but that again doesn't change our treatment plan and all. It will remain the same, no problem at all. Yeah. So that's the station. So make sure in the first UTI station, do not forget about confusion, because this station is, I would say, an extension of the previous station. Yeah. So in this patient, vitals are deranged. It's in sepsis. So just do the management, IV fluids and the antibiotics and everything. Back pain. 58-year-old patient, back pain. That's it. This is, I would say, one of the most controversial station of Plab2, back pain. 58 back pain, what it can be. There are lots of things it can be actually. And this patient is giving severe pain from last 2-3 months and not getting relieved by taking paracetamol also. He's taking like full course of paracetamol, but still in pain. So what can be the differential actually? There are lots of differential actually. For example, it can be osteoarthritis. Of course, 58-year-old patient can have osteoarthritis, can have osteoporosis. It can be disc prolapse. So you can ask, if this pain started after you are lifting any heavy objects or something, or if it is going to your legs or something. If this pain is going to the legs, the numbness and tingling sensation, so it might be disc prolapse as well. Might be pyelonephritis. Pyelonephritis can lead to a loin pain, maybe back pain, and same with the kidney stones. But when you take the history, because back pain and severe back pain from last 2-3 months not getting relieved. So what it can be, actually it can be something serious as well. So when you take a bit more history, sometimes this patient is giving the history of weight loss, loss of appetite, everything. Then it might be, we might have something serious in our mind, like it might be cancer, yeah. So make sure that cancer, you have to rule out if it is cancer or not. But if patient is giving weight loss, loss of appetite, then we are a bit concerned. Now the question comes, which cancer it can be? There can be a lot of cancer which can metastasize to the back. For example, it can be prostate, can be pancreatic, can be kidney, can be renal, can be lung cancer, can be gastric cancer, lots of cancer. Yeah. So what happens is, uh, this station, as we have written in the script, we have made it like a prostate cancer, because sometimes this patient will give the history of prostate symptoms. In that case, you can say it is prostate cancer. Yeah, so that's a simple one. Patient will give you lots of finding positive related to prostate, might give you frequency, nocturia, hematuria, and dribbling or incontinence. Lots of finding suggest that it's BPH and maybe it's prostate cancer, but it's not the case always. It's not the case always. It's not giving this BPH findings always. Then what it is? See, sometimes he's giving only frequency. Frequency only is not a thing that you can say it is prostate cancer. A patient who is 58, 60-year-old can have frequency. That doesn't make it that it is prostate cancer. So this station, sometimes it is prostate cancer when you have lots of finding positive regarding prostate. Sometimes this patient is giving only back pain and weight loss, nothing else. In that case, you have to be very cautious and try to rule out all the other cancer which can go to the back, which can spread to the back, like all these cancers. Prostate, you will ask question for prostate. Pancreas, which questions you can ask? You can ask if there is any itching, if there is any yellow discoloration of the body. Yeah, because pancreas, mainly the head of pancreas, it can lead to these kind of things. Kidney, you can ask any hematuria, any lump and bump, any lump in the loin area maybe. Lung cancer, any cough, hemoptysis. Gastric cancer, you can ask any tummy pain, any indigestion. All those things you can ask to rule out other differential of back pain. In this station, not always concentrate only prostate cancer. It might be something else as well. Yeah. So all these things, if it is, for example, if it is prostatic stuff, then again we will ask these questions: frequency, nocturia, urgency, hesitancy, incontinence, poor stream, emptying, and dribbling. The same way we will ask all the things. And definitely in this, you have to ask cancer symptoms. Yeah, cancer symptoms will be positive, but we may not be able to make the diagnosis of prostatic cancer because he might not give you the symptoms of prostatic cancer. Yeah. So what can be the risk factor? Risk factor, actually, the risk factor you can have for prostate cancer actually might be the age, like ethnicity. The Black, African, or Caribbean, they're more prone to have this problem. Family history again, and smoking. Yeah. Investigations. All these investigations will be doing routine blood, urine test, PSA, DRE, digital rectal examination, transrectal urethra, transrectal ultrasound, and CT MRI. Again, CT MRI we do for staging, but in this case, make sure rule out everything. Lung cancer, X-ray. Pancreatic cancer, do pancreatic enzyme, amylase and lipase. Yeah. So rule out everything. Ultrasound actually is just for abdomen if there is anything wrong with the abdomen. Treatment, same stuff. Treatment, you just have to do in the same way. Do ICE: idea, concern, expectation. So what do you think what it can be? You are having this problem, you're having this back pain for the last 2 months. It's a chronic back pain that you're experiencing, and it presents with the history of weight loss and loss of appetite, and you're feeling tired for last this much of time. So what do you think what it can be? And patient will say, doctor, is it cancer? If there is one of the possibility it might be cancer, we need to investigate you further, and mention about all the investigations. So again, all these things use ICE, idea, concern, expectation. Very, very, very important. They started asking this question as well, the back sprain. My patient is 30, came with acute back pain, 30-year-old back pain. So talk to the patient, assess him, and give him the further plan of management. This station actually, what can be the cause? The back pain can have again multiple causes. So again, the same differential that we discussed here in the previous station. The differential will remain. Some are same, like it might be osteoarthritis or osteoporosis or disc prolapse actually. Yeah, and pyelonephritis and kidney stones and all. Patient is young, so cancer is a bit unlikely. I mean, the prostate finding unlikely. 30-year-old prostate doesn't make much sense. Yeah, just a second. So you can ask about all those things. This patient is giving you a very a nice history actually. It is actually the back sprain. Why it's back sprain? Patient is telling doctor, actually I was playing squash. I was playing squash, and uh, this time actually I played after so long. I mean, I was not playing it for the last 1 month, but now suddenly I started playing squash, and I played a bit longer time. I played for a bit longer time, so that's why. Okay, so that was the thing. That's the main hint for you. But definitely you rule out other stuff as well. You can ask if there is any numbness, tingling sensation in your arm, in your legs, and because it can be disc prolapse. That's very important differential. And again, kidney stone, pyelonephritis. Again, everything you need to rule out. But make sure ask this history. The disc prolapse is very important differential in this station. And he's giving the history of this what do you say, squash, that he was playing squash. That is his main concern, and his main concern is also in the management, when I can play squash. I'm sorry. So the thing is, in this station, the main concern is also squash in the management. First of all, what investigation? Which investigation you think that we should do? Back pain. We'll be doing all the routine investigation. Yeah, blood test you can mention, and definitely mention about the X-ray. You can do an X-ray. X-ray will be really helpful in this particular scenario. So X-ray will be able to rule out other things. If there is any fracture or something, but definitely it's not a fracture because patient is not giving very severe pain. Yeah, and after playing squash, it's like a bit more like clear it's a sprain, but still rule out other things as well. Don't only concentrate on the back sprain. Rule out everything else. Disc prolapse is very important differential in this case. Ask if there is any weakness in the lower limb, or if there is any uh, numbness or tingling sensation. It's very important. Ask about the work of the patient. If he's lifting heavy object or if he's moved any heavy object, that can also lead to any disc prolapse or something. All right, so it's very important station. The management is just doing the investigation, and then the sprain management. It's like take a bit of rest, but don't like complete rest. Also, maybe a bit mobile. But this patient is asking, can I play squash? The thing is, in the beginning, maybe avoid playing squash for some time and just take a bit of rest. That is the management. Sprain is actually simple management. We can do is price harm. Do price, avoid harm. So for price is PRICE. Actually, we have written it in one of the ethical station. You will be getting that maybe tomorrow. You will be able to see that price, PRICE. P means painkiller. We usually give painkiller if there is a treatment of any sprain. R is rest. I is ice compression. We usually give for a few days in the beginning. And C, PRI and CE. Then E is elevation. We tell the patient to elevate, but this is a back sprain, so we can't elevate anything. Yeah. And then harm. We usually say avoid harm. Harm means H means is the heat. We usually avoid heat in the initial few days. Then A, harm A. A is alcohol. Should not drink alcohol that time. R is running. We should not do running or excessive exercise. M in massage. We should avoid massage as well. So actually, that's the management of sprain. So all these things you can mention it to the patient. Tell the patient to take a rest for sometimes. Yeah. And this patient sometimes asks, I mean, are you going to refer me to the physiotherapist? Yes, definitely we can refer this patient to the physiotherapist. That's the thing. After that, we have this station now, hematuria. Patient is, let's read the question. Patient is 55, present at the clinic with hematuria. Hematuria can have lots of reasons. Plab1, 1700 first question. Patient is something like 50 years old, came with painless hematuria. And what is the investigation that we are going to do? Flexible cystoscopy. That is the 1700 first question, if you remember. So this station actually based on that particular thing. This patient 55 presents with hematuria. When you elaborate it, this patient will tell you it's painless hematuria. Old patient, painless hematuria is bladder cancer unless proven otherwise. That is the thing that you need to follow in this station. Differential can be these differentials you can mention. Hematuria can be because of bladder cancer, UTI, kidney stone, or enlarged prostate. These things can lead to hematuria, but we are not going to miss our red flags, which is bladder cancer. So that thing will definitely be there in our mind. So you'll be asking all the associated symptoms of this, like we'll also weight, appetite, and all. But this thing, the thing is, in this patient is not giving this kind of symptoms positive. He's not giving history of weight loss, appetite loss, or anemia symptom. It's just giving this painless hematuria. So associated symptoms you are going to ask. You are going to ask all the other symptoms like weight loss, loss of appetite, anemia symptoms, frequency nocturia, UTI symptoms. Yeah. But this patient might give you slight features for UTI or BPH symptoms maybe, because patient is 55. Just to confuse us, he might give you some BPH symptoms as well. But usually he's not giving weight loss, loss of appetite, anemia symptoms. But make sure when you see hematuria, which is painless in old patient, it is always cancer, bladder cancer, unless proven otherwise. So don't miss that. Very, very important finding. And what can be the differential of this bladder cancer? Usually it's smoking or aniline dye. So you can ask the professional patient if he's working in aniline dye factory or something, because that's one of the risk factors. Yeah. So investigation will be this thing like routine blood will do, urine test, and flexible cystoscopy. Do not miss flexible cystoscopy, PSA, DRE, ultrasound, CT, MRI, everything. Because you know what happens is this patient sometimes gives some history of some BPH symptoms positive. And also when you mention about the examination, I would like to do general physical examination, vitals, and I would like to do digital rectal examination. So this patient sometimes, this examiner sometimes give the history of BPH. The examination, BPH is there, the prostate enlarged. See, prostate enlarged is a different thing, and painless hematuria is different thing. So just to confuse you, they might give this history positive. They might give that examination of prostate positive. Prostate is enlarged. They might give you that as well. But don't get confused. You can do the management of prostate as well, but do not miss bladder. Don't miss this bladder cancer. Don't miss flexible cystoscopy. Yep. And how will you disclose that you have bladder cancer? It's the same way we will disclose as we do in previous station, like ICE, as we did in hemoptysis, as we did in back pain. ICE, idea, concern, expectation. So, for example, his name is John. John. So he told me that you're having this blood in your urine, and it's been like for last 1 month, 4 episodes you already had. So what do you think? What it can be? So he will get an idea and he will tell you, doctor, is it something serious? Is it cancer? Then your life becomes easy. That's the thing. That's the thing we need to mention. Yeah, it's an easy one. But make sure don't get confused in this station, because it's very easy to get confused, because examiners sometimes give the finding of prostate. So don't get confused in that. Don't get confused. Loin pain. 27-year-old patient, loin pain. Talk to the patient, discuss the plan of management. All right. Sometimes instead of loin pain, they will give you acute back pain. So they might give you acute back pain or loin pain. Yeah. So these things we have to make sure we are not messing it up. 27 presents with the loin pain or acute back pain. So don't consider this is that this station is that back pain. No, this is different one. Once you will start asking questions, it will be very clear which loin pain or back pain it is. So loin pain, actually the most common differential, and the young patient is 27, young patient, stone in any urinary tract. Maybe patient has UTI, pyelonephritis. See, make sure this stones, kidney stone can easily become pyelonephritis. Yeah, if patient is giving a history of fever and shivering, rigors, it is pyelonephritis. But this patient is not giving that history. This patient is giving that I'm having pain in my loin, which is going to my groin. So it's loin to groin. But when you ask about fever, or when you ask about this, what is shivering and all, patient is saying no. So it is not pyelonephritis, or it's not UTI. But make sure, do not miss that finding, because these kidney stones, urinary tract stones, they can easily lead to pyelonephritis. So don't miss it. Don't miss it. It is really, really important. Yeah. So urinary stones, UTI, pyelonephritis, 3 very important differential. Renal cell carcinoma is a bit like I don't think so, not that good differential, but red flag maybe, fine. Pneumonia, I mean, again, a bit uncommon, but lower lobe pneumonia can lead to this. Yeah, lower lobe pneumonia can present with the loin pain. Associated symptoms. So these are some associated symptoms like nausea, vomiting, fever, or burning sensation in the urine. That can be some associated symptoms here. A risk factor, what can be the risk factor actually? See, first of all, it's a station of stone. So if patient is taking high protein diet, patient is young, so their chances maybe is going to gym or taking high protein or vitamin or some mineral supplement or something that can lead to this stone. And if not taking like enough diet, enough fiber diet, or not taking enough fluid, so that might be the reason of having this problem, hyperparathyroidism. So all those things you need to ask here is a risk factors. Examination is general physical vitals and abdominal examination. Investigation. So investigation of choice is CTKUB. We'll definitely do urine examination and routine blood. Why we're doing urine examinations? For example, if you found something called nitrates leukocyte, then it is UTI also. It is UTI secondary to stones. Yeah. So in that case, what you have to do, you have to give antibiotics as well if it is UTI. But in this case, usually examiner is not giving any finding here, and it's okay. But make sure anytime if they give shivering, they give any fever, it might be pyelonephritis. And if they give anything in the urine hair, in the urine dipstick, you may have to give antibiotics as well. But the investigation of choice is CTKUB. Because of CTKUB, we'll be able to know if it is CTKUB will tell you where is the stone and what's the size of the stone, because treatment depends on that. Management is nothing much. Management is symptomatic actually, and give IV fluids, challenge to the patient, and patient will be fine. And it depends on the size of the stone actually. And the cutoff range here in this country is 4 mm. If the size is less than 4 mm or 4 mm, wait and watch. Just drink plenty of water, you'll be fine. Most of the stone will come out. But if the size is more than that, maybe we have to do some interventions. Yeah, then we can mention about the surgery and all, but you don't have to go in detail of that surgery and all. Antibiotics is only in that case if you suspect it's UTI or pyelonephritis. So if you have some symptoms of UTI or pyelonephritis, you can go for it. And we may give tamsulosin as well. Why tamsulosin? It will just relax the muscle, the neck of the bladder. So the chances that the stone will come out. Yeah, stone will come out. And one more thing that you can mention, that GP usually prescribe a stocking. In this country, what GP does, they usually give us stocking. So they tell the patient that filter your urine from the stocking, because if we are able to find the stone, so we can check that stone. Yeah, we can check and we can find out why the patient having stone, what's the cause of this stone, and we can help, we can prevent these stone happening again in the future. So that is what you can mention. And some general advices like you drink plenty of water, and if he's taking any low fiber diet or high protein content or something, so you can tell the patient avoid those things. And please do not forget to give warning sign. To give warning sign for which warning sign we should give? We should give warning sign related to pyelonephritis, like if you develop fever, shivering, do come back to the hospital. That is the thing that you need to mention. Yeah. Dysphagia. It's a patient, a 60-year-old, came to the hospital with difficulty in swallowing. Patient came to the hospital with difficulty in swallowing. Talk to the patient, discuss the plan of management. This patient might be female or male, anything can happen. So what's the differential? See, patient is 60, dysphagia. First thing should be esophageal carcinoma. That should come in your mind. Ask about weight loss, appetite loss, and anemia symptoms. Yeah. Second is esophageal stricture. Yeah, I mean, if patient had like, for example, corrosive ingestion, so that can lead to stricture. Esophageal spasm. How will you rule out it's not esophageal spasm? How will you make sure it is cancer or it's not spasms? How will you differentiate actually? In cancer, it is a progressive dysphagia. First start with the solids, and then it might lead to problem with the liquids as well. But in spasm, it started with the liquids and solid at the same time. Cancer, progressive. First solid, then liquid. Spasm together for solids and liquids. Yeah. Oh, sorry, that is achalasia. I mean, how will you rule out achalasia and cancer? Cancer is progressive. Achalasia is with both the things together. I mean, with the solids and liquids. Spasm is, you can ask a specific question for spasm. I mean, if your condition is progressing by eating hot or cold food, because Patient can have spasm if they are eating like any cold food, maybe because of that, maybe something like hot food or something. So that is spasm. Cancer is progressive. Spasm can be because of hot or cold food. Achalasia will problem with the solids and liquid both at the same time. It can be GORD as well, can be myasthenia. So you can ask as the day progresses, so your symptoms get worse or become better. So this is how you can ask about myasthenia as well. You can ask about the pharyngeal pouch as well, maybe the bad breath or halitosis. You can ask. Lots of differentials are there, but the patient is giving very clear-cut history that initially I was struggling to eat solids and now I'm struggling to drink fluids as well. So that is simply they are saying it is cancer. Associated symptoms can be cough, heartburn, loss of weight, appetite, anemia symptoms, and back pain. Back pain again, if it is matched. Yeah. Risk factors will be like alcohol, corrosive, and of course, age is again a risk factor that you don't have to ask. You already know that. Alcohol, like any corrosive ingestion or any alcohol ingestion, like can lead to this. Examination is general physical examination, vitals, and we will examine this oral cavity like mouth and food pipe, the esophagus, and abdominal examination. This is what we mentioned. Investigation, routine bloods, and endoscopy. And management, you know, it is same way as we did in the previous station. That how will you tell it is cancer? Again, by doing the same stuff. That is ICE: idea, concern, expectation. Idea, concern, expectations. You have to do it in the same way. So tell the patient, like you told me, that you are losing weight, you are not having a good appetite, you're feeling tired, and you're not eating as before, and you're struggling to swallow these days, and it's going on for the last couple of months. So what do you think what it can be? So this is how we are putting it as a ICE: idea, concern, expectation. So same way you need to do in this station: idea, concern, expectation for this cancer. It is esophageal cancer. Let's do one more. That is hematemesis. Okay. So in this, you are in a patient is 27-year-old present to the hospital with hematemesis. Take history and discuss the management plan. Take history and discuss the management plan. Yeah. So blood pressure is given. It is 110/70. Pulse is 100. Temperature is 37. SpO2 97. Respiratory rate is 17. Actually, the vitals looks normal. There's no problem with the vitals. If you look at it, you can see a pulse maybe a bit high. It's 100. Yeah. So what can be the cause of hematemesis? Again, there can be a number of causes for hematemesis. Yeah. So problem may be like maybe any liver problem, and liver disease can lead to this. Gastric erosion. Yeah, gastric erosion. Acid peptic disease. Yes. I mean, peptic disease, peptic ulcers can lead to this. Peptic ulcer can be because of alcohol, can be because of painkillers, and also there can be a lot of underlying causes. Yeah. Esophagitis, Mallory Weiss tear. I mean, and Mallory Weiss tear, you can ask about binge drinking or what kind of vomiting it was. And carcinoma. Carcinoma was a bit like unusual, 27-year-old female. Yeah. So liver disease, gastric erosion, acid peptic disease, and esophagitis, Mallory Weiss, esophageal carcinoma. Lots of differentiation. Associated symptom. I mean, this patient is giving the history that this morning I had like 2-3 episodes of hematemesis, and that's why I came to the hospital. But right now I'm feeling a bit better now. So associated symptom, you'll be asking about tummy pain, feeling sick, heartburn, all those things. And risk factor, you know, that alcohol, painkiller, blood thinners. And actually this patient is saying, yes, so when you ask about the past medical history, are you taking any medication? Yes, doctor, I'm taking painkiller, I'm taking NSAIDs. And you're like, you're taking NSAIDs, okay, but why you're taking NSAIDs? And she's like, doctor, you know, I'm taking it just for my hangover. So actually she is giving you lots of findings. She is giving you the findings. She gave you 2 findings. She gave you NSAIDs use. She gave you history of alcohol abuse. So 2 things we will get positive, which can lead to peptic ulcer disease. That's the cause actually in this case. Yeah. And examination, you know, physical vitals, abdominal and digital rectal examination you can mention. And then investigation, routine blood, ECG, we can mention endoscopy and X-ray. See, X-ray, why? Just to rule out perforation, just to show I'm a safe doctor. Endoscopy to find out the cause of bleeding. And if you found any cause, any acid peptic ulcer there, we can treat it also. Diagnostic and both the things we can do. So we will be able to diagnose it, and we can treat it also at the same time. So we need to do endoscopy. So the treatment is actually NPO. Don't forget to tell the patient nil or orally, because we need to do endoscopy. So what you need for endoscopy, you need to have patient nil per oral. Yeah. So nil per oral, that is the thing. IV fluids and PPIs and symptomatic. One thing now, we don't usually give PPI straight away, because if you give PPI before doing endoscopy, what can happen? You may mask the finding. You may not get the exact finding when you're doing endoscopy. So we usually give PPI after we have done with the endoscopy. So mention PPI, mention about acid suppression, but after endoscopy. So tell the treatment is NPO, IV fluids will give, and we'll prepare you for endoscopy. Yeah, and we'll try to find out the cause, and we can treat that cause as well. And later on, we'll give you IV PPI. That's the thing. Yeah, and symptomatic is like, patient has lost a lot of blood. She's vomiting. She vomited 2 or 3 times. So let's say we're doing routine blood investigation. If needed, we might give you some blood products as well. That is the thing that we need to mention. That makes it really important. So that was a Himmat mass station. Yeah. So this is all about surgery. Surgery, we didn't have many stations. It's just like 9 stations we had. So surgery was a small topic. Next